Mr. Chairman, dear colleagues, thank you for the opportunity to present this cooperative experience on the definition of the surgical complexity index in neuroblastoma resection. I have nothing to disclose. You may recall the preliminary experience presented last year on the possibility of assigning a severity score to image-defined risk factor in neuroblastoma surgery. A surgical complexity index was introduced to stratify surgical risk and consequently applied to risk factors encountered in a given patient. In our retrospective single-center analysis, a direct correlation between surgical complexity index and the IDRF score was found. The present study aims at overcoming the limitation of that preliminary experience with the definition and validation of a shared surgical complexity index based on expert consensus through a Delphi methodology. A task force composed of 15 surgeons with proven experience in neuroblastoma surgery was involved in a Delphi consensus study. 27 shared items classified in 3 domains, preoperative, intraoperative, and postoperative, and predictive or indicative of surgical complexity were selected. Surgeons were then asked to attribute to each of them a degree of operative risk according to the following classification: standard risk, somewhat higher risk, quite higher risk, and very high risk. An agreement was defined as the achievement of at least 75% consensus focused on a single answer, or alternatively, the simultaneous fulfillment of a following condition: at least 60% consensus focused on the prevailing risk category, and at least 75% consensus in the sum between the prevailing category and the immediately closest category. In this slide, you can see the shared items selected and classified in the 3 domains. It took 3 Delphi rounds to reach an agreement on 25 out of 27 items. All experts complete the first 2 rounds, and 86.7% of them complete the 3rd round. Consensus was now reached in metastatic status and intraoperative complication with normal residual function. Based on this agreement and stratification, a severity score was established for each item, ranging from 0, meaning standard risk, to 3, meaning very high risk. The definition of the surgical complexity index speeds us to the next retrospective data collection and calculation and validation of the index for each patient operated. Following steps will consider the individual analysis of image-defined risk factors and the attribution of a severity score for each of them. So there's a long way to go, and it seems that we're at the very beginning of the climbing, but we're definitely moving on. I hope I'll give you some updates in the next episode. Thank you.